Welcome to the American College of Obstetricians and Gynecologists Video History Project. Today we're very fortunate to have with us one of the giants of our specialty, Dr. Donald Ostegard, a man who has radically changed a major aspect of our specialty. Don, thank you very much for coming.
Thank you very much for inviting me. I feel privileged to be here.
Well, we are very privileged that someone of your stature would be willing to come in and talk to us. Let me ask you a little bit, though, before we get into your major development. Tell us a little about yourself. Where did you grow up? Where did you go to college?
Okay, I was born and raised in Los Angeles, and I've pretty much been in Southern California all my life. After I did my high school education, I went to UCLA as an undergraduate for 3 years, and then I spent 4 years in San Francisco at the University of California School of Medicine in San Francisco. Then I came back to Southern California to what is now called Harbor UCLA Medical Center, part of the UCLA system. And I did my internship and 4 years of residency there. And when I finished my residency in 1968, I then became an assistant professor at UCLA. And I've been an academician ever since. In fact, I still have a professor in residence appointment at UCLA at this point in time. So whenever I'm in LA, I'll stop by and do a little teaching.
I think that's very good. Now, you said you were at Harbor UCLA. That's actually a hospital that's been well known for many years for strong teaching and strong innovative aspects of our specialty. Who was your mentors there?
Okay, interestingly enough, the day before I came to the hospital as an intern on the GYN service, Dan Michel had finished his residency. So he and I basically started together at that point. He is faculty, me as an intern. And Luigi Mastriani was our first, our professor at that time, followed by Ted Quilligan. And we thought we were in the business of training people to go be department chairman, because most of them left to be department chairman, and then Dan Michel took over the department until he left to join Ted Quilligan up at USC. Now, one of the faculty members at the time was Dwayne Townsend, really my mentor during that period of time in the hospital. And he and I worked on several projects, cryosurgery of the cervix, training nurses to take pap smears, and things of that nature. And then during my residency, my other mentor came along, Jack Robertson. Jack Robertson brought his urethroscope and his CO2 cystometer. And this is where I really began my interest in female urology because of his influence with that urethroscope, diagnosing various conditions in the urethra itself and in the bladder. And so those are basically the important mentors in my career. Another one actually was Dan Morton up at UCLA. He was department chairman at that point in time. And he and I wrote a paper on multifocal carcinoma of the female genitalia. And that was really my first real academic paper. And I was very proud to have Dr. Morton as my mentor at that point.
Don, you just named the names. If that we were a sports team picking an All-American team, you just picked an All-American team.
Yeah, thank you. It was great.
You trained under some of the very best. But then you went on. What encouraged you to continue on in at that time called female urology?
Well, Jack Robertson, as I mentioned, we established a female urology clinic at Harbor UCLA and started to teach the residents his technique, but I became a little concerned because it seemed like everybody, when you put CO2 into their bladder, they had an unstable bladder. And so I said, well, this can't totally be right. So I then decided that when I had my sabbatical that came up in 1975, that I would, number one, review the world's literature that existed at that point in time about the subject, and then to go visit various centers in the world. So I went to Norway, I went to England, I went to San Francisco, and each of these individuals were doing sophisticated testing. One was doing video urodynamics, and the other two were doing urodynamics using either microtransducer catheters or balloon-filled catheters. And so with that, I said, yes, there's a lot that needs to be done here. And so I duplicated their system at Harbor UCLA, and we had a physiologic recorder that was about 3 feet wide, 6 feet tall, you know, to measure our urodynamic parameters. And as I'm sure you're aware now, they come in little tiny boxes at this point. It's very, very different.
Well, tell me, what parameters were you most interested in?
Well, incontinence was the big one, and the causes of the incontinence. And evaluating the bladder itself, I mean, what was called detrusor sphincter dyssynergia at that point in time, which basically meant that the bladder contracted when it wasn't supposed to. Try to determine why did that happen and what could be done to treat it. And the other part of this was with the use of the microtransducer catheters, we could determine that the standard operation that we had at that point in time, the Kelly plication, wasn't really doing the job that it should be doing, with only about a 30% success rate. And so we could determine the pressures inside the urethra. We could watch the pressures fall as the bladder contracted. And so we had a very sophisticated diagnostic system for things that otherwise had just been diagnosed clinically, and not always correctly. So it added objectivity and scientific basis to the field.
I would expect at that time you were probably the only unit in the United States doing that sophisticated testing.
Well, actually, Dr. Tanago in San Francisco had his he had four balloons on a catheter to measure pressures. But that was with air, and air is compressible, as you know, so not quite as good as the microtransducer catheters. But actually, I was the first one in the country to use the microtransducer catheters for this purpose, having seen them used in Scandinavia.
What do you think made your interest be so readily accepted around the country?
It wasn't readily accepted, actually. As an aside, I gave a presentation through the New York Obstetrical Society, and comparing Kelly's plication with the Birch procedure, which was the other up-and-coming standard operation at that point in time. And I met an awful lot of resistance because the docs were saying that my Kelly plications always work, my patients always do well. But the studies had shown the success rate was only about 30%. So it came begrudgingly initially. And I think it was after 4 of us sitting in a living room in Orange County, California, and brought up the idea of a society of female urology, which we called the Gynecologic Urology Society at that point, which is now the American Urogynecology Society. So once we got the society going and people started coming to the meetings, the first were kind of sparsely attended, maybe 60 people or so, but now the meetings are well over 1,200, 1,300 individuals attending the annual meetings. And when that happened, it stimulated a lot of other people to look more carefully at their clinical practice. And as a part of this, 1978, I trained the first fellow in urogynecology. And this was extremely important because my plan was to try to get people into the training program who I thought could be academically oriented and start their own training programs elsewhere. And this worked out extremely well. The first fellows I trained all went to various institutions, started their own fellowship training programs, and as an aside, in 2006, one of the drug companies decided to do a family tree of me. And of the 35 or so that I had trained at that point in time, I think I had about 250 descendants, you know, fellows, grand fellows, great grand fellows, and so forth. And so obviously people were thinking about this and thinking, how can I do better for my patients? And that was the whole idea with this whole thing, to get better patient care for women in the field of urinary incontinence.
Why do you think took so long before the American board really recognized this as an issue and something that was absolutely important?
Well, why? I can't say for sure. Well, one thing happened actually back in 72 or 73 when the major boards were being formed. A past president of ACOG was in our department, and he was asked, should there be one in female urology? He said no, he didn't think the field was big enough at that point in time. And I think that's part of the reason. People really didn't think it was that big of an issue. But once you started putting it on a scientific basis, everything changed. And that took 10, 15, 20 years to get to that point. And you know, the American Urogynecology Society worked very hard, you know, to educate the up-and-coming leaders in the field. And that has worked tremendously well.
Today, it's actually probably one of the major aspects of what we do as an obstetrician gynecologist, or need to do.
Yes, need to do. I think that's true. Yes.
But it has also slowly developed internationally in terms of development, because I know that FACOG just only a few years, well, about 10 years ago, finally recognized that this was something they could have a special interest group in.
That is correct. A good friend of mine, Oscar Contreras Ortiz of Argentina, was working with FACOG since the late 70s, early 80s, trying to get FACOG to recognize it as something that was an up-and-coming specialty. And before he passed away, I think he managed to do that. He got FACOG interested in it. And again, that was very important. And in 1976 at the FACOG meeting in Mexico City, Dr. Axel Engelmann Sundberg from Sweden got together a group of us and formed the International Urogynecology Association. And that association has grown by leaps and bounds. In fact, it's going to have its 43rd meeting in Vienna next month, in June actually. So the whole concept has spread very dramatically. And there are members, I think, from 90 different countries that attend those meetings. And so, you know, gradually the world is being educated, let's say, on the importance of this.
I think you're more than a father. You're probably a grandfather and a great-grandfather now with all the trainees.
Could be.
Let's go back to resident education. There's still a concern that in resident education, there's not enough attention paid to the female bladder and the problems with it. How do you think we're going to eventually change that?
Well, you know, it's been gradually changing over time. And as I mentioned earlier, my training of fellows who would go to various institutions start their own training programs. And within that, the residents would be educated as well. And one of the difficulties has been getting enough board-certified subspecialists into the programs that have residency programs, to get them there so that they can teach the residents during their 4 years of residency experience. Well, I guess it's 3 years now. I had 4. 4. Yeah, 4. Okay. So anyway, it's taken a while, and I think it's a manpower issue in some degrees to get the teachers in the right places, you know, to educate them. But you've kind of tremendously long ways since, you know, the early days when my program was probably the only program in a recognized residency program that was training, you know, the individual residents. And it's been very gratifying to see this grow by leaps and bounds, and it's continuing to grow. And I think that it can only get better.
Well, what do you see about the future of urogyn?
Well, I think it's going to become more and more important as time goes by. We are at the stage now where there is an increasing number of older people who are going to need care. And these individuals may frequently develop problems with incontinence. And because of that, we need all the manpower we can get to take care of those individuals. Geriatrician urogynecologists, I guess, you know, at least those who can go in.
Maybe another subspecialty.
Could be.
When I trained, when you trained, the standard method of handling this was vaginal hysterectomy and a A&P repair.
Yes, sir.
What is your opinion of the status of the A&P repair today?
It has changed tremendously. You know, the prolapse surgery is very much a part of this subspecialty, because if you have a cystocele, for instance, there may or may not be incontinence associated with it, and you have to then determine, is there potential incontinence here, that when I put this bladder back where it belongs, is this patient going to become incontinent? So there has to be a preoperative evaluation of some sort in order to make that kind of a determination so that the correct procedure is done. And I've been a little bit dismayed as the way some of these things have happened, particularly with the advent of the polypropylene slings and polypropylene meshes for vaginal repairs, many of which have now been withdrawn from the market because of their adverse events associated with them. The mid-urethral sling, developed by Ulf Olsson in Sweden, is still, I think, a very important part of this, but still it's from polypropylene and create many, many issues many years down the road. And we don't have papers going out long enough to tell us what really happens after 10 or 15 or 20 years. And the problem with the mesh is it degrades and it sort of disappears, and the efficacy disappears over time. And not to mention the problems with the pain that's associated with mesh. And I guess I'm getting off on a tangent here, but
No, that's perfectly all right. I think you're raising very valid points.
Yeah, and this has been something that I've been very concerned about, and you probably don't keep track of this sort of thing, but the courts sort of do, and the companies that have made the meshes have been sued, and there's been a verdict over $100 million against the companies. The most recent one was $67 million. And there are still many thousands of women out there who have sued, but their cases have yet to be heard. So it's a major issue. And unfortunately, the doc saw that, well, I can do this very quickly, and I seem to get good results, and the patients seem to do well. A lot of assumptions here, as you can see. You know, they sort of followed along without really looking into it very carefully. And I think that the word has gotten out that this may not be the cat's meow that people thought it was when it first came out.
Well, the FDA has actually pulled some of them already.
Yes.
And they probably should pull a lot more.
They should, absolutely.
Do you think the fact that in OBGYN residency training programs, we've gotten away from vaginal surgery and made it so easy to do slings and others, so we've gotten away from the typical birch procedures, those types of technical things which are not that easy to do, and throwing in a sling is simple.
Yes.
So, you think that's added to it?
Well, you know, this has been a major concern of mine. And we have a whole generation of urogynecologists who have been trained in programs that did not teach the basic things you were talking about because they were using mesh. Mesh really enveloped these programs so quickly that these trainees, that's all they could do. And heaven help them if they get a problem in the retropubic space and they've never been there before. How are they going to handle that problem, that bleeding problem, you know? doing birch procedures was the best way to learn the anatomy of that area, but they're not done that commonly anymore. But I think there is now a switch back to doing things the natural tissue way, rather than some prosthetic device. And I think that we're going to see a change in the education, the surgical education at least, of our residents coming up, and the fellows too, in terms of doing these particular procedures, which work very, very well. I mean, the Manchester procedure, a very old procedure, 95% success rate at 5 years. You can't beat that. And then no meshes involved at all.
Probably 99% of residents don't know what a Manchester procedure was.
I think that is very, very true.
Sometimes we tend to forget. Do you think, as you look forward to the future, that we're going to see the urogynecologist, and I'll just use that as a terminology, to become a much more specialized type of a practice as opposed to today's type?
Yes, I think so. In fact, the practicing gynecologist who has grown up in this same time period has the same concerns. And so the urogynecologists are becoming more and more important from the standpoint of a tertiary level referral for this individual, because they do not have the skills to do these procedures. And you just mentioned, don't even know the name. What's a Manchester procedure? It's a wonderful operation, absolutely incredible. And the urogynecologists, many of them now don't know much about that either. They're going to have to learn. So there's going to have to be a big switch here in the types of procedures that are being done and the people who are doing them. And I think that the urogynecologist has really become the go-to person for those tertiary level referrals when the physician, the garden variety gynecologist, doesn't have the skills, to handle this particular patient.
Well, Don, it's been wonderful to talk to you.
Well, thank you.
I mean, I really meant it when I said earlier. I think you are the one that established the specialty, at least in the United States. Had it not been for you, I think it may have been developed in sometime in the future, but have been a long way off.
Yeah, probably so, and I'm very glad to have been a part of it. Better health care for women is what it's all about.
Better health care for women, and you're one of the giants that did it.
Thank you, sir.
I want to thank you very much for sharing your ideas and giving us a little bit of that history. That was some things I didn't know.
Thank you for having me. I really appreciate it.